Welcome, everybody, and thank you for attending our first annual Health Sciences Health Academy virtual event, Surviving of Self, SOS, How the COVID-19 Pandemic Has Impacted Our Mental Health. I'm Deidre Lassane, the Director of Development for the Department of Psychiatry here at the University of Pittsburgh. Today, you will have the gracious opportunity to hear about groundbreaking research and advancements in the health sciences. We have dynamic speakers, which will be 5 panelists representing the Department of Psychiatry at the University of Pittsburgh School of Medicine and the University of Pittsburgh Medical Center, UPMC. Today, they'll share presentations about how the COVID-19 pandemic has impacted our mental health, the mental health crisis, specifically related to the impacts of COVID-19. I will be introducing each speaker before they present, and then there will be a live Q&A at the end for questions. Let's get started. For our first speaker, you're going to hear from Dr. Gina Perez. Dr. Gina Perez is an associate professor of psychiatry at the University of Pittsburgh School of Medicine in the Department of Psychiatry, and she also serves as Senior Director for Medical Student Education and Clinical Faculty Development. In addition, she is Associate Chief of the UPMC Behavioral Health Network and Telepsychiatry. Dr. Perez will be speaking about telepsychiatry today in her talk presentation. Dr. Perez, welcome.
Thanks so much. Hi, everybody. Hope you're having a good start to your day. Thanks for joining us. So I thought I would go over a couple basics about telepsychiatry, and I'm hoping to make some of this just really practical tips that we've learned over the past few years as we've converted to a lot of video visits for care for patients. And so we can go ahead and go to the next slide. Right. So I thought I would start by sort of stepping back and taking a look at the growth that's happened within our own telepsychiatry department and across our network. And so pre-pandemic, we had been doing telepsychiatry. We started in about 2007 and 2008. And I remember that I used to get so excited to say that we did 10,000 video visits a year. And then COVID hit, and a lot of the regulations that had been holding back our growth in telepsychiatry were lifted. And we really rapidly transitioned in the outpatient realm, our 400,000 visits that happen a year to virtual. And that includes a lot of group services, individual. This is not just psychiatrists seeing somebody through video. This also is therapists, peers, case managers. We did a very rapid shift, and we learned a ton during this transition. And I would say in 2022, we really kind of settled to almost, it's about half and half now, in person and video visits. And there are a lot of things that go into when is it appropriate to do a video visit? When does it make sense clinically? When does somebody have the right access to be able to utilize a video visit? And so I'm going to share some of those lessons learned with you. So next slide. Okay, so one of the first things to think about with a video visit is connectedness. Especially in psychiatry, it's so important to have a good relationship with your therapist or your psychiatrist, the person who's really delivering the care and who you are trying to build a relationship with, and make sure that you can trust them. And I think it's important for all of us to step back and ask, do I genuinely feel connected over video? Or in some rare cases, if it's a phone appointment that's being done, do I really feel connected? And that really goes in both directions, and it can change over time based on your situation, your symptoms, knowing what information you may wish to share with your psychiatrist. And so ask yourself, do you feel as connected over video? Most appointments end up being a hybrid of in-person and video. So it's usually not just, all video. The other part of connectedness too is to think about your actual IT connectedness. And so do people have we'll jump to that slide in just a second. And so do people have access to the right smartphone that has video and microphone capabilities? Do they have stable internet? You can imagine that during any of your medical appointments, especially in psychiatry, I would say, but really any appointment, it is a very big deal if you don't have stable internet and you're just trying to hear each other, and really critical moments could get lost if there's not good connectivity. And so this was one thing that I know you'll meet Dr. Gannon down the road here, who's also going to speak today. We talked very quickly at the beginning about which of our patients are not able to be connected from an IT perspective when a lot of our appointments were virtual, and how is that impacting them? How can we make sure that we're still getting care to patients that can't connect by video? And all of our clinics did still offer in-person availability, but right as COVID hit, most people always chose a video. So next slide, please. There's a new elephant that's in the room now with video appointments, and it is IT tolerance. So how much can you as a patient or a provider tolerate? And this is a really important consideration as a provider too. So I think about, as somebody starting a session, the last thing that I want is to have them feel frustrated in any way. And so my new skill set is, how can I coach somebody through an appointment and getting connected, not having them feel stressed out if something doesn't go just as planned? So I want to make sure that the IT component doesn't interfere with what we're trying to accomplish in the appointment. And so this is sort of it's been new for all of us for the past few years. Okay, next. I think it's important to revisit privacy. And we all are so used to using our phones, and we so easily FaceTime with people or connect through texting and other ways on our phones, that sometimes in a medical appointment or a therapy appointment, you can forget to sort of recheck. Okay, do I have a private place to talk with somebody? It is an appointment. It is very important to have your privacy. I've had, people pick up the video call while they're on the bus, while they're in the grocery store, while they're not in a room by themselves. There are other people in the room too. And you just want to set up the appointment so that you have the best chance to really be connected and to share anything personal that needs to be shared. And so some people don't have access to a private location, and then they may not be the best. It may not be the best choice to choose a video visit for them. And so I think just rechecking that on sort of both sides. I've had patients join on and say, like, for example, the person who was in a grocery store, I also have to remember, like, this is still new territory for everybody. And so I always just try to approach it with kindness and still figure out a way to do at least a check-in by phone, and see if it is appropriate then to try to reschedule once I know that there's not an acute issue happening, and to do it with kindness, because they're actually just trying to show up for their appointment, but circumstances didn't work out. Okay, and so the next slide, please. The next piece is to ask yourself, why a video visit? And what are the benefits of it? What are the challenges of it? What really works for you? What doesn't? And so as we've shifted and our volumes have really increased, we do somewhere over 200,000 video and phone visits a year. Very minimal in the phone category. So you feel like you're able to be as connected with somebody, or is there a piece of avoidance that happens and the video visits are being used? Or is it more that this person wouldn't have shown for an appointment? And so any connection, any way that we can keep them connected is really valuable. And so I feel like it's always weighing that clinically as you're trying to make this decision. The other piece is it is really convenient for people to be able to do a video visit, and for really meaningful reasons. You have a busy home life, you barely can get time off of work, you don't want to travel through Oakland, through all the construction and the parking nightmare. Those are very legitimate reasons. And there are many times where I've had patients come stressed when they're coming in person because they couldn't find parking. And so, just trying to figure out what is the right balance. Next slide, please. And so personally, I see patients who the majority of my clinical work is patients who are adults who have autism spectrum disorders or intellectual disabilities. And so there have been some beautiful moments that have happened and some lessons that I've learned personally through video visits. So a couple of beautiful things that happen with video visits are getting to know people in a different way, meeting their pets. This is my cat Scoobs on my front porch here. And getting to see family members that I didn't get to meet before. I have one person who is incredibly stressed to come into the office in person and is very agitated when he's in the office. And over video during COVID, turned on the screen and was able to see him making breakfast in his own home and smiling, and I'd never seen him smile. And so there really were some beautiful things that have come out of video visits. And I've also been reassured when I see somebody in person again, and I realize, okay, I don't feel like I missed anything. This is good. And then there have been times that have been the opposite, where I feel like, I feel so much more connected when we're seeing each other in person. And so again, it is all about finding that right balance, working together as a team, and it's fluid over time. Okay, I thank you kindly, and I'll look forward to hearing the rest of the speakers.
Sorry about that. And I mute myself. Thank you so much, Gina, for your presentation. Up next, we will have Nadine Melham. Nadine Melham is an associate professor of psychiatry and clinical and translational science at the University of Pittsburgh School of Medicine in the Department of Psychiatry. She is also the director of the program for the neurobiology of stress response and suicide at Pitt. Dr. Melham will be presenting on the impact of COVID-19 of mental health in youth. Welcome, Dr. Melham.
Thank you. Thank you for organizing this event, Deidre, and for inviting me to participate. So now that we are at the end of the public health emergency related to COVID-19, we are ending at more than 6 million deaths worldwide and about 28,000 or more in a 28-day period currently. And the United States is the top and has ranked as on the top in the total number of cases as well as deaths throughout the pandemic. Next slide, please. There is an unprecedented mental health crisis and a surge in suicidal thoughts and behaviors among youth that has started prior to the pandemic and that was exacerbated by the pandemic. And this has led the US Surgeon General to declare a public health emergency for an increase in emergency department visits for suspected suicide attempts that were higher by about 51% in adolescent females in early 2021 compared to 2019. Recently, these numbers has decreased actually, which is great news. And however, the decrease was in mental health for mental health concerns and emergency department visits for general mental health concerns, but we're still seeing high rates of ED visits for suicidal behavior and overdoses in youth. Next slide, please. Suicide ranks as the third leading cause of death in the United States in youth, and it is the second among those who are 10 to 14 years of age. Prior to the pandemic, we have been observing an increase in suicide rates between 2000, where the age-adjusted rate was 10.4 per 100,000, to 13.9 per 100,000 in 2019, which is about 35% increase in these rates. We were excited about a decrease in rates that was starting to happen in 2020. Next, please. However, the recent provisional suicide rates from the CDC are showing an increase in suicide rates in 2021. Next. And these rates were higher in both males and females, but more significantly higher in males. And those males who are 15 to 24 years of age showed the highest percent increase by about 8% between 2020 and 2021. Next slide, please. There is a disparity in suicide rates that we're seeing by age and racial categories. We're seeing an increase in suicide rates in more recently born cohorts, and we're seeing also higher rates in those who are 5 to 10 years of age, with rates that are highest among the American Indian, followed by Black youth. Between 2010 and 2020, we're seeing also an increase that is highest in Asian or Pacific Islander youth by about 81% increase in suicide rates, and about 37% in American Indian youth. There were disparities in the COVID-19 pandemic with higher rates of deaths and hospitalizations due to COVID-19 among racial and ethnic minorities due to limited access to care, as well as the disproportionate jobs that were deemed as essential workers during the pandemic. There's also continued to be some disproportionate access to care, with 36% of COVID-19 patients that were aged more than 20 have been treated with Paxlovid. However, the rates are 30% lower among Black and Hispanic youth. And Black and Hispanic youth and people in general are also less likely, and about half less likely, to have received the bivalent booster so far. A lot of the pandemic-related stressors that have been associated or have been precipitating the mental health crisis are due to increase in parental or caregiver death that we have seen in the United States, with more than 140,000 US youth have lost a caregiver or a parent due to COVID-19. Only in the first period of the pandemic up to 2021, and worldwide the number was about 1.1 million. There's also an increase in economic stress and parental unemployment, increase in social isolation and loneliness and virtual schooling, surges in firearm and alcohol sales in the United States. There was also an increase in family conflict early during the pandemic and during the lockdown periods, reduced access to social supports even during the time of losing a parent or caregiver or a loved one, where people were not able to do the rituals that are associated with celebrating someone's life. And there were reductions in psychiatric services early on during the pandemic, which were buffered by the use of telehealth. However, recent studies have shown that there continue to be racial and ethnic disparities in access to telehealth visits. Throughout the world, there was a study that have looked at more than 23 helpline calls in countries, including the United States, during the pandemic. And what this study has shown is the increase in the number of the helpline calls during the pandemic, as well as, next please, as well as these patterns have decreased during the decrease in the rates of the pandemic and the rates of the the rates of transmission in different countries. And what this study has shown that prior to the pandemic, there were most of the calls were due to relationship problems. However, the changes during the pandemic, most of the calls were due to loneliness and increases in fear, including fears of the infection. Also, what this study has shown in the United States, there was an increase in helpline calls due to suicidal ideation during the most stringent policies due to reduce the transmission of the virus. However, there was a decrease in these calls due to suicidal ideation when there were supplemental index and supplemental support from the government in various periods of time. Next. There is also an increase in risk for psychiatric disorders that was observed in people who have been affected with COVID, with the largest study in about 62 healthcare organizations looking at electronic health records early in the pandemic, showed about 33.6% of people affected by COVID have received a neurological or psychiatric diagnosis within 6 months of COVID-19 diagnosis, and 12% had their first such diagnosis. Similar results were also observed in children and adolescents who were affected by COVID, who were at increased risk for an incident diagnosis 1 to 6 months following the infection. Early in the pandemic, and as soon as we moved our research operation to working from home, we started to do our stress response study to try to assess the impact of the restrictions and COVID-19 on our community. So we did a survey that we made it available through Facebook, Instagram, and PIT+Me through the University of Pittsburgh that targeted individuals who were 13 years of age and older, healthcare workers, and people who lost a loved one due to COVID-19. This slide shows the rates in the adolescents, where we were surprised with how high the rates of clinically significant symptoms, depression, anxiety, PTSD, prolonged grief among those who lost a loved one, and suicidal ideation, with rates about 35, more than 35 to almost 60%. Among youth. Early when we looked at these results, and this were during the period between April 27, when we got IRB approval for the study, and July, and those were during the period where the lockdown was removed, but there were still some policies to reduce transmission. I was surprised at these rates. However, unfortunately, these rates were replicated later on by looking at other studies, other emergency department visits that do support the exacerbation of the mental health crisis during the pandemic. Next, please. When looking at the predictors of depression, clinically significant depression symptoms, loneliness was one of the predictors. In addition, sleep problems was a significant predictor, perceived stress, the increase in social media use since COVID-19 were also some of the predictors in youth of depression symptoms in youth. We've also found that loneliness was also a common predictor, not just for depression symptoms, but all of the psychiatric symptoms. These findings really reinforce the need to monitor psychiatric symptoms among vulnerable populations, specifically adolescents, not just in mental health visits, but also in pediatric and primary healthcare visits. We need to learn also from the mistakes of the pandemic that were done by really having preventative approaches that increase social connectedness safely during the pandemic. We also continue to need a concerted public health strategy that address the mental health consequences of COVID-19 that we are still living through. And we do need to better understand the mechanisms through which COVID-19 infection impact risk for mental health in youth. Thank you for listening. This is a slide showing the mental health resources for people who are struggling to reach out to these numbers. Thank you.
Thank you very much, Dr. Millam, for your presentation. Please be sure, participants, to reach out to some of the mental health resources that were laid out. We're going to move on to our next presenter. Our next presenter is Dr. Jessica Gannon. Dr. Gannon is an associate professor of psychiatry at the University of Pittsburgh School of Medicine in the Department of Psychiatry. She is also the medical director of ambulatory behavioral health informatics, the medical director of comprehensive recovery services, ambulatory clinics, and the CRS director of education and training at the UPMC Western Psychiatric Hospital. Dr. Gannon will be presenting today on schizophrenia and COVID-19. Welcome, Dr. Gannon.
Thank you, Deidre, for that nice introduction. And I'm sorry that some of my titles are so long. We should be more brief in how we assign titles. But yes, I am going to present today on schizophrenia spectrum disorders. But before I really dive into the meat of my presentation, I did want to provide some definitions, explain a little bit about what these diagnoses mean, simply because there's a lot of misinformation out there about schizophrenia, and there's a lot of stigma associated with that misinformation as well. I apologize because some of you in the audience probably know quite a bit about schizophrenia. Those of you who have been in the healthcare field or who have a loved one with schizophrenia, maybe some of you even have schizophrenia yourself, right? So apologies to those of you who are already in the know, but I just want to empower everybody with what I think is really helpful information. Okay, so schizophrenia and spectrum disorders, what are those? Well, that includes several different diagnoses, including schizophrenia, schizoaffective disorder, delusional disorder, and the key core features of those disorders is the presence of psychosis or psychotic symptoms. I want to take a step back and say that a lot of us, regardless of whether or not we have schizophrenia spectrum disorders, will experience psychosis at some point in our lives. We see psychosis related to mood disorders, to getting really sick, ending up in the medical hospital, having delirium, substance intoxication. You can get psychotic with substance intoxication. You can even get it with like sleep deprivation, severe stress. But the issue that we see in schizophrenia spectrum disorders is that the psychosis lasts for long periods of time and lead to significant impairment in people's lives. Okay, so with the symptoms of psychosis, you're probably kind of at least a little bit familiar with, like, you know, having delusions, hallucinations. Usually in this spectrum of disorders, we talk about hearing voices, and you can also see disorganized speech and disorganized behavior, which can make it really difficult for the person to, you know, meaningfully engage with others. But, you know, some people with schizophrenia, you know, again, friends, neighbors, colleagues don't want to talk about having schizophrenia because there's so much stigma. And then there's other groups of folks who do have a more severe illness burden. Some of that can be due to lack of access to mental health care, which is a real problem in this country, as you guys probably know. That's no big secret. And also those sometimes disease-related factors impair their people's involvement with mental health. So lack of insight is a big problem in many mental health disorders, but particularly in schizophrenia spectrum disorders. So sometimes folks will think they don't need treatment, they don't need to take medications, and that doesn't always have the best outcomes. Also, while our medications, our antipsychotics, do a pretty good job in addressing psychotic symptoms, that's why they're called antipsychotics, they don't do much to treat these group of negative symptoms that you see on the far right. And those can be really impairing in schizophrenia because people who have negative symptoms, it can really suck the motivation out of them. And it can make it very hard for them to plan important things like going to the doctor and making their doctor's appointments. So that can lead to significant impairment in folks' lives. Okay, next slide, enough of that. Okay. So schizophrenia, the lifetime prevalence of schizophrenia is really only 0.7%. Some studies show maybe 1%, but not a ton of people have schizophrenia, but really it's equally common in men and women and across like wide socioeconomic demographic groups. And I mentioned this, or I hinted at this before, but it is important to note that that lack of mental health care utilization is thought to heavily contribute to relatively high rates of homelessness, unemployment, and incarceration that we do see in this population. Incarceration is usually due to petty crimes. You know, I think there's a lot of stigma related to schizophrenia and violence out there, but our patients are actually much more likely to be victims of violence than perpetrators of violence. So important for all to remember. Next slide. But schizophrenia, even though it only affects 0.7% of the population, is actually quite costly. And we spent the excess economic burden in the United States in 2019 was $343.2 billion. I want to just direct your attention to the orange bars at the bottom, though, because most of those costs are attributable to two things. So caregiver burden, so folks decreasing work hours or quitting their jobs to take care of loved ones with schizophrenia, and premature mortality. So our patients dying younger than they should. Next slide. So why is that? Why do our patients have premature mortality? Well, medical comorbidities, there are high rates of chronic medical conditions in the population with schizophrenia. So we see high rates of things like diabetes, high cholesterol, hypertension, COPD, because we have high rates of smoking and coronary artery disease. Next slide. And so that premature mortality can be up to 15 to 25 years, and that's pretty significant. And again, most people dying of natural causes like cardiovascular disease related to that heavy medical comorbidity. Why is that? Why do our patients have high rates of diabetes and cardiovascular disease? Well, some of this may be related to medication side effects. Some of our meds do make people gain weight and have a metabolic burden associated with them. But certainly we see a lot of difficulties with access to the medical system, causing health disparities in our population, and things like poverty and those illness-related factors like those negative symptoms not making it to the medical doctor definitely also play a role. But so does stigma, because we see over and over again that when our patients do show up to their medical appointments, they don't receive the healthcare screening and counseling that they deserve. They don't get adequate workup of presenting complaints, and they don't get that monitoring and treatment of comorbid medical disorders. And we also see sometimes that they don't get treatment for life-threatening medical conditions that meet the evidence base. Okay, so we were not surprised going into the pandemic that we saw that our patients, when they were getting COVID, they were getting quite sick with COVID, and that we were seeing higher mortality rates than we were with the general population. We were also seeing higher rates of our patients becoming infected with COVID. Some of that we thought was probably due to, we do have high rates of people living in congregate housing, and we do have high rates of disability, but when people do work, they were often essential workers. So we weren't too surprised by these higher transmission rates as well. But I want to point out the Namani from this journal here, this publication, her findings was that schizophrenia was second only to old age as a risk factor for dying of COVID-19. So very, very serious. Okay, next slide. So we knew in our clinic that it was really important for our patients to do all they could to not catch COVID. And so we knew that vaccination in this population was super important, but unfortunately, the CDC didn't make schizophrenia, didn't add people with schizophrenia to their list of high-risk conditions for vaccine prioritization until October 2021. And that was only through the advocacy of patients and families that patients with schizophrenia were added. Now, I also have to note that, we were worried, not just due to lack of access kind of issues for our patients, but that, we were seeing lower rates of COVID-19 vaccination in countries where access really wasn't a problem, in places like Israel, and these are studies here that I'm citing. And so we decided to see, well, how are we doing in Pittsburgh? How are we doing, especially in a group of very high-risk populations, patients on clozapine. Clozapine is a medication we use, an antipsychotic, when patients have failed other antipsychotics. We prescribe clozapine, but it is associated with a risk of immunosuppression. So we were particularly worried about this group of patients, catching COVID. And spoiler alert, but good news is we actually did really well. Our patients did really well in getting vaccinated. And in fact, at the end of the summer of 2021, they had higher rates than the surrounding Allegheny County. And I think that some of that, thank you, has to do with our advocacy and encouragement and just kind of constant reminders to get vaccinated. Okay, next slide. Okay. Also, to try to mitigate risk of patients getting COVID, we also did a lot of telepsychiatry. Now, Dr. Perez talked about this, that, most of our patients in the Western psychiatric footprint, UPMC behavioral health footprint, did do video visits. But because of access issues, not being able to get onto the 5G, not having wireless, not always having the latest smartphone, and then cognitive impairment, some of our patients just not being able to really, use the apps to do the video visits. We did a lot of phone calls with patients. And some of our patients needed to continue to come in because that was just clinically wise. Sometimes seeing someone, being in someone's presence, sometimes we have to do neurologic exams. We needed people to come in. And so we still had people coming in, and some people didn't even have phones, right? Sometimes our homeless populations, our more transient populations also needed to come in. So this is the purple here. These are the face-to-face visits are in-office visits. So we continue to do those throughout the pandemic, and the blue visits are telemedicine visits. You see a lot of orange here because we do have high no-show rates, right? Which probably doesn't come as a surprise. All right, next slide. All right, so again, so we did have some people who had to come in. I mentioned clozapine patients need labs, and that is federally mandated, although that was relaxed somewhat as the pandemic progressed. But even when patients no longer had to get those labs as often, they still continued to come in or engage in kind of optional telepsychiatry visits with nurses as just kind of check in between doctor appointments. So you can see that, patients still wanted to talk to us even when they didn't have to, which was nice. And we published those findings in a peer-reviewed journal called Schizophrenia Research. Next slide. Now, some patients really, really had to come in. It wasn't an option in order for them to maintain their current treatment. And this group of patients were those who receive injectable antipsychotic medications. And a lot of times patients who are on injectable antipsychotic medications, some people opt to do that because it's more convenient than having to remember to take a pill every day. But some people we heavily nudge in that direction because, cognitive impairment makes them more inconsistent with taking meds. And also we have some people that, they have like that wavering insight. Sometimes they're not sure if they need to take meds. So a lot of times folks who are on long-acting injectables really, really benefit from them. And over again, they've been shown in studies to reduce hospitalizations, right? And we definitely wanted to keep people out of the hospital during COVID. So we continue to offer long-acting injectables, of course, and we did a lot to really keep people socially distanced when they came in for this and just general treatment, just general office visits. We really expanded our waiting room footprint. We staggered appointments so that, patients wouldn't overlap as much, and much thanks to our nurses for being able to do that and keep everyone safe. So this finding that we published here just shows that we didn't actually have any dropouts or any more significant dropouts than we usually do in terms of long-acting injectable treatment. Okay, so thanks all, and I could talk about this for hours, but I will go ahead and cede the floor to our next presenter and look forward to hearing your questions later. Thanks.
Thank you so much, Dr. Gannon, on your presentation. Up next, we're going to move along to Dr. Sarah Peterson. Dr. Sarah Peterson is Associate Professor of Psychiatry and Psychology at the University of Pittsburgh School of Medicine. Dr. Peterson will be speaking about the social detriments of racial disparities surrounding substance use during the COVID-19 pandemic. Her research is focused on identifying social and structural influences of inequities in alcohol and substance use outcomes. Welcome, Dr. Peterson.
Thanks so much for having me. I'm excited to be here today. I went to the Lizzo concert on Saturday, which was epic. And I'm going to start with a quote from Lizzo. She said, "The fight still isn't people of color versus white. It's the people versus the system built to keep us down. And the system is man-made, but is made of no man. Everyone, regardless of class, creed, culture, and ethnicity, can fight the system and help to break it down." Next slide. To get us started, I'm going to talk a little bit about prevalence rates of alcohol use disorder across different racial and ethnic identities. And, kind of understanding that alcohol use disorder is a heterogeneous disorder, and you can have mild, moderate, or severe. To meet criteria for a mild alcohol use disorder, you only need to endorse 2 symptoms and 2 criteria. So it actually is a pretty low threshold at this point. If you look at this data just as a snapshot on epidemiological rates, you can see that there are differences across racial groups in our country. So Asian or Pacific American individuals have a lower likelihood of having an alcohol use disorder than white individuals. Black and Hispanic individuals are around the same level of prevalence as white individuals, and Indigenous individuals have higher rates or likelihood of alcohol use disorder. One of the things that's really important to notice is that there are crossover effects and different developmental trajectories in course of alcohol use disorder across racial or ethnic identities, and there are crossover effects that happen in mid-adulthood. This data also includes people who never drink at all, and those things also really influence your likelihood of having an alcohol use disorder, obviously. So when we look at data that doesn't include people who don't drink, these look very different. And there are increasing alcohol use disorder prevalence for almost all minoritized racial groups. And we're going to talk about sort of why that is. So my research is largely focused on understanding alcohol inequities for Black Americans. The reasons why are that this is a really complex understanding and topic. So there's higher rates of abstention for Black Americans compared to white Americans, slower increases in alcohol use in adolescence. However, amongst individuals who drink, Black individuals experience more problems from drinking, including likelihood of dying, including social problems, physical problems, legal problems, in part driven by racial profiling, and meeting criteria for an alcohol use disorder at comparable levels of use, as well as persistence of alcohol use disorder after onset and inequities in access to care. And COVID-19 has worsened inequities in general, and alcohol is not an exception. So during COVID-19, we saw alcohol use increase for a lot of people in the United States, although not all, and that data is actually pretty interesting, showing that about 23% to 29% of individuals in the United States who drink actually decreased their alcohol consumption in the early stages of the pandemic. But on average, people did increase, and it increased more depending on if you had pre-existing depression, anxiety, stressors, and if you had a history of an alcohol use disorder. So for people with a history of an alcohol use disorder, there were short-term increases in alcohol consumption that were noticed that were pretty substantive, including an estimated 79,000 life years lost, an estimated 295,000 more alcohol-related hospitalization, and an estimate of $5.4 billion that could be attributed to this increased alcohol consumption. And the largest increases in alcohol consumption, as well as alcohol-related problems, were for non-Hispanic Black adults, individuals in that mid-adulthood range where we already saw kind of that crossover effect, and individuals with minoritized identities having worsening outcomes during that time, and for women. So again, my research has really been focused on understanding inequities in alcohol problems. And I started working on this topic in graduate school when I realized people really hadn't cared to research it. It's actually more complex than that in terms of even NIH wanting to fund it. But I place all of this within a socio-historical context where we have structural racism leading to many different forms of stress and discrimination, which have downstream effects like drinking to cope with stress, drinking to cope with discrimination, potential differences in how rewarding alcohol is when you're drinking it, as well as craving alcohol, which ultimately may drive the inequities in alcohol-related problems. And I worked on this theoretical review paper with my friend Tamika and both of our mentors early in graduate school, and that has really set a foundation for my research and as well as my interests. So one of the things that I want to talk about is the really notable effects of structural racism on how we drink, how easy it is to access alcohol, and the interconnection between redlining and alcohol environment. And this is a paper that just came out this year. And I'm highlighting it because this is New York City in the years 2014 and 2018. And you can see sort of the historically redlined neighborhoods that they're highlighting in those little red boxes. And then you can see kind of the density of what they're modeling. And in the, right to sections, you can see just how much more dense alcohol outlets are in historically redlined neighborhoods. And that has been done on purpose. So people have purposefully kind of opened up more liquor stores, opened up more bars in historically redlined neighborhoods. You can also see how this tracks with the density of violent crime, and alcohol and violent crime are also interrelated. And so the structural racism, the socio-historical context here is really profound in my research and very important to consider when we're thinking about treatment implications, when we're thinking about what this data can mean. So when we also then are thinking about interpersonal racial discrimination, that has increased substantively for all groups who have minoritized identities, including LGBTQ+ individuals, since 2016. That data is not uplifting, but is really important. And one of the reasons why it's important to what I study is that within Black American samples, individuals who experience more discrimination also have increased likelihood of drinking more than intended and experiencing more problems from alcohol use. There's also different domains of discrimination that may be differentially related to outcomes. And some of them that we've been examining in our lab are assumptions of similarity. So, telling somebody that they look exactly like another person who happens to be of a shared identity, even though they look nothing alike. I get told pretty frequently that I look like Ellen DeGeneres. I don't. And she's actually like, I don't know, 25 years older than me, but that's cool. It's not, but that is an assumptions of similarity. Assumptions of inferiority, that this person probably can't have an education or won't have an income. And then assumptions of criminality. So kind of that reaction of moving across the street from somebody. And those things are really important to consider and differentiate when we're examining the effects of racial discrimination. So you can go to the next slide. I'm not sure where, there we go. So one of the things that I wanted to show all of you on this call today is just how prevalent discrimination experiences are in Pittsburgh. This is data that we've collected in our lab where people have their smartphones and we actually text them throughout the day and ask kind of what's going on. And we ask if they've experienced a discrimination event. And they can then tell us why they think they experienced it. Was it due to my race? Was it my age, physical appearance? And you can see here in a 17-day period that 61% of the Black young adults in my sample reported experiencing at least one discrimination event that they attributed to their racial identity, relative to 8% of white adults. But you can also see that kind of across the board, Black individuals are experiencing more discrimination based on physical appearance, based on age, education, income, as well as even religion. And I think that part is getting at some of the intersectional components that as clinicians and providers, we need to be considering. Go to the next slide, please. So again, one of the things that then happens is that people start to drink to cope with stress. I drink to reduce my negative mood, my feelings, and those are elevated in Black individuals compared to white individuals as well as a result. And that has a direct association with experiencing more alcohol-related problems. One of the things we model in my lab is actually looking at how people experience alcohol. So we dose people with a moderate dose of alcohol in a very kind of controlled setting. And then we talk to them about what are your experiences and what does that look like for you? And we try to induce stress in a standardized way, which if anybody wants to hear more about, please email me and you can come into my lab. But I'm looking at the alcohol effect of kind of reducing that stress. And one of the things that we find here is that Black adults actually have a reduction in their stress that is more profound than white adults. And that may be being driven by kind of the chronic elevated stress from experiencing structural and interpersonal discrimination. You can see this here when I'm modeling that. Oh, can you go back for a second? From that pre-stress to the mid-stress block. You can go to the next slide, please. The other thing that I think happens over time is that we pair that kind of the stress reduction in association with that, that's really reinforcing, with then craving alcohol. Shout outs to Tracy Kennedy for running these analyses, but we actually looked at the association between momentary increases in stress as well as momentary increases in craving alcohol, that strong urge to drink, and found stronger pattern of association for Black individuals compared to white individuals. So overall, one of the take-home messages that we keep finding, and that has really come out in more and more of the COVID-19 period of time, is that there is a drinking to cope pathway that is actually worsening as COVID-19 has expanded and exacerbated many of the inequities that people are experiencing related to healthcare, related to kind of the being an essential worker, having to be out in that environment. And one of the things that I'd really like people to take home is that as clinicians, discussing the impact of discrimination is really important and really relevant in alcohol use disorder treatment, but even just access to that and bringing that into the room, as well as considering how we can bring this out into a mobile health intervention, meeting people where they are in their own environment. And that the experience of minoritization may be increasing the rewarding effects of alcohol and other substances. And I feel like the public policy implications of recognizing the impact of structural discrimination, socio-historical context, can really help fuel sort of decreases in these inequities over time. So one of the things that we need to do is integrate across all of these levels and place people within a socio-ecological context. So not just focusing on the individual, because we know that everybody's embedded in their environment, and that chronic stress load then could influence how you experience stress, how you react to stress, and that your neighborhood and structural factors are contributing to that too. So bringing that in within this lens into a way of actually addressing some of these inequities, I think COVID-19 has showed us repeatedly the importance of doing that. One of the last things I want to end with is when you're reading about research, when you're understanding some of the data that are getting presented, when you see that in the news, there really is a notable lack of representation in who is getting studied and also who is doing the research. And we published a paper on this topic that came out looking at the American Journal of Psychiatry. And we read 125 of their most recent scientific articles in psychiatry. And only 43% of the studies even described the racial or ethnic identities of the participants. And those that did, 95% of the participants were described as white or Caucasian. And the second largest group was non-white, which gives us no information, and that actually isn't a racial identity. So when we're hearing about some of these things in the media, please know who's being excluded from them and the implications of that. And I was pretty stunned by that, in which case is why I put up a picture of myself as a kid picking my nose, because I felt like this is pretty gross. If you could go to the next slide. Just want to acknowledge my team that does this research with me, as well as the community partners that really share their lived experiences, community organizations, and substance use treatment providers to inform all of our research in my lab. Thank you.
Thank you so much, Dr. Peterson, for your presentation. We're going to move on to our final presenter, and that's Dr. Sansi Jacobson. Dr. Sansi Jacobson is Associate Professor at the University of Pittsburgh School of Medicine in the Department of Psychiatry. She is the Program Director of the Child and Adolescent Psychiatry Fellowship and Triple Board Program at the UPMC Western Psychiatric Hospital. Clinically, she works at the STAR Center and specializes in suicide prevention. In addition, she's the co-chair of the UPMC Graduate Medical Education Wellness, Environment, Learning, and Living, which is WELL Committee. Dr. Jacobson today will be presenting on physician mental health.
Thank you so much, Deidre. And I'm so excited to be on the panel with these other amazing colleagues. So I promise actually that we will wrap up my section pretty quickly so that we can have some interactivity with you all in the audience. And so feel free to start peppering the chat with your questions, the Q&A section, and we'll be getting to that portion quickly. If you just go back for 1 second, I want to go to that first slide because I'm a proud academic mom, and We physicians don't love being referred to as healthcare heroes. And yet, look at these guys. These were our incoming interns back at the beginning of the pandemic in June of 2020. This is when we were all pretty darn scared, right? We were 6 feet apart, we were wearing masks, no one was vaccinated, and they're in the auditorium at our hospital at Western Psychiatric. Just the month prior, they were identifying as medical students, and there they are as doctors walking into the mix. They've spent their entire training during the pandemic, and now these brave young doctors are our chief residents, our seniors, and our fellows, and we're so very proud of them. So let's talk a little bit about how the pandemic has impacted doctors. We know that physicians have unique stressors, right? Even before the pandemic, patients are sick and some patients die, even in psychiatry. There are medical errors, there's system dissatisfaction. The system is wonky, the system is a little broken, right? And we're right at the forefront of that. And then there are sort of the chronic stressors related to difficulty unplugging from work and work compression and the rest. And you already heard a little bit about it, but we also aren't immune to loneliness. Next slide, please. We're also not immune to mental illness. In fact, our rates of depression are higher than the general public. We have equal rates of substance use disorders, and yet we don't like to talk about that, right? And then suicide is a real risk for physicians, higher risk than many other professions. It's been estimated that about 119 physicians die by suicide annually in our United States. Next slide, please. So this is all pre-pandemic, and then COVID-19 hit. Next slide, please. So physicians across all discipline faced a variety of stressors related to the unknowns of PPE and lack of protective equipment, the secondary trauma of taking care of patients who were unwell and who did not survive. The complexity of wearing multiple hats, being educators, being at-home parents, being educators of our own children, while also having full-time jobs as physicians. The technology frustrations of switching, especially for psychiatrists who were able to switch quickly. You heard Dr. Perez talk about how we pivoted so phenomenally, and yet a lot of us were working out of our homes where our children were also online trying to do their online classes. It was a lot. Next slide, please. And Dr. Melham already spoke about the child mental health crisis, so I won't belabor the point, but I am a child psychiatrist and I work in suicide prevention. And so obviously physicians were stressed, psychiatrists were stressed, and boy, we child psychiatrists were really stressed. Next slide, please. And you can see that here, the clinic where I work at the STAR Center, which is a suicide prevention clinic for teens, we had over the course of the pandemic, an increase in, on the left there, you can see from July 2019 through June 2020, we had 493 clinic referrals. And you can see that that just climbed over the course of the next 2 years of the pandemic. On the right, you can see there some of the data that Dr. Melham already presented, or that we were not alone here in Pittsburgh. Child mental health and emergency department visits skyrocketed throughout the pandemic. Next slide, please. And so did that happen here at Western Psychiatric? Oh, well, interestingly, when we look at our data from our psychiatric emergency setting, we didn't actually have an overall increase in patients who were seen per se over the course of the pandemic, but we are seeing up there on that top chart is that an increase in wait time. Why is that? Well, as you can imagine, everything was more complex during the pandemic, but also we were seeing a disproportionate number of child cases, which sometimes can take more time, but also that we were having staff shortages and people were leaving the mental health and medical world. Next slide, please. And so how does this affect physicians? Well, sure enough, if we look at burnout rates, pre-pandemic, the rates were high. They were about 45% in 2019. They climbed and rose all the way up to 60% in one study of physicians who endorsed burnout in a 2021 study of more than 20,000 physicians. And the intent to leave similarly climbed. Next slide, please. Here at UPMC, similarly, we saw burnout rates not as high as the national averages, but some interesting trends here. We check our burnout rates across all of our physicians every 2 years. And burnout rates were very high at the beginning of prior to the pandemic. They climbed for probably in 2019, like it did nationally, though that was a year off for us in our survey. But you can see that it actually dipped in 2020. And we really see that as that's the time that we felt empowered. We knew what we were doing. The vaccines were becoming available, and we were starting to become more savvy in helping patients survive the pandemic. Unfortunately, you can see that the trend did not continue in that positive light, and that more recently this past fall, when we resurveyed our physicians, burnout rates are climbing. Next slide, please. Is it just burnout? If the pandemic is basically over, then why are physicians getting worse? Well, we know there are lots of contributors to burnout, much above just the languishing that we're feeling from being in a pandemic. It's related to EHRs, medical records that are clunky, and a variety of other issues. But also we're starting to research here the question of moral injury and disenchantment. So it's not just a work phenomenon, but maybe our physicians are actually experiencing more of a trauma syndrome, where they came in very idealized around the field of medicine. And when they see things that don't align with what they think they're trying to do in terms of helping patients and families through difficult times, and they're not capable of doing that for a variety of different systems related issues, that this can lead to hits of moral injury. And then over time, the damage done to one's sort of moral compass can result in a concept of disenchantment. And I'll just quickly tell you, next slide, please, that we did research that here in our interns during the time of the pandemic. And we did find that our interns came in highly idealizing the field of medicine, but by the end of their intern year, 67.7% of them had a significant reduction in that idealization. 53% felt like they had experienced something that could have resulted in moral injury. That 18.6% said they wouldn't choose the profession again, and that 39.5% wouldn't encourage their children to pursue a career in medicine. Next slide, please. So what are we going to do about this? Well, it's a big question, but I will say that I'm very proud to be at UPMC, where we are investing time, money, and expertise into trying to approach physician well-being. You can see there on the left, my dear colleagues, Dr. Berlin and Dr. Losi, they're in charge of attending and physician well-being, as well as sort of well-being across the field. And then Dr. Vu Nguyen, who's a plastic surgeon, is my co-chair on the GME committee. Next slide, please. And we created something called the Well Toolkit, which basically is education for well-being champions to help physicians with topics that I've discussed today around burnout and depression and suicide risk. You can actually go to that QR code and go to our website and download those free resources. Next slide, please. And in fact, more than 17,000 people have gone and downloaded our resources. So we're really proud of that, to have created that toolkit to help physicians across the nation. Next slide, please. So ultimately, this is my wrap up. We need to break the culture of silence, of maladaptive perfectionism in medicine. We know that doctors are at risk for the same thing that all human beings are at risk for, and we have our own risk factors too. So next slide, please. And so here at UPMC, we have amazing resources. So if you happen to work with physicians, scan that QR code. This is our well-being resources. I'm not going to go over what we have, but we're very resource rich, and we're very fortunate to be at a place where doctors can get help. Thank you for your time.
Thank you so much, Dr. Jacobson, for your presentation on physician mental health and wellness. We are now going to open up for our live Q&A to take some questions for the presenters. And so I will jump right into it. For question number 1 that we have for the live Q&A, it is, this is for Gina Perez. It says, are there any studies or data that compare the effectiveness of teletherapy or virtual therapy with in-person therapy?
Great question. I will put in the chat a link to a review that looked at that question specifically, and they're thought to be equivalent and with the same rates of people staying engaged in treatment, and then looking at improvement in depression symptoms. And so, yeah, that's a quick answer to your question.
Okay, for our next question here, this is for Dr. Peterson. This is from Leanne. She said, you stated that Black adults have a reduction in stress that is greater than white adults when under the influence of alcohol. I missed the why there. Would you please repeat or elaborate?
That's a really great question. This has not been studied yet. So my lab is studying that. One of the hypotheses that I have is the chronic cumulative stress load and exposures to discrimination that have been shown in white adults to increase that kind of like stress response, but it has not been examined when looking at this specific example. But that's my hypothesis. Stay tuned.
All right, moving right along. This is for Dr. Jacobson, specifically in this Q&A. It says, what are your thoughts on increasing needs services / clinical staff? I'm certain you're all frustrated, as the rest of us, with the long wait list and limited therapists. Do you have any solutions?
It's probably above my pay grade, but absolutely, you are not alone in being frustrated. And the system is frustrated, of course, too. And so, you know, for instance, UPMC, they're making bonuses for support staff or nursing staff to try to support underserved areas. There just aren't actually enough people to serve the communities that we need to serve. And with people leaving the field, it's super challenging. So I think ultimately we need to be recruiting smart young people into the field. We need to be getting people to come back now that the pandemic is over, who are well trained. And then we need to fix the systems so that people want to stay and within healthcare. And so that's sort of the well-being movement of really helping with improving the efficiency and the effectiveness of medical systems, so that we medical providers can do the work that we're trained to do and be more satisfied and effective and efficient in the work we do. So great question, and probably not a satisfying enough answer.
I can comment a little bit on that too. You know, I think that any advocacy you guys can do, especially at governmental levels on things called like pay parity. I know that sometimes, despite the federal government's best interest and laws that they've passed to make sure that this happens, behavioral health care still doesn't get reimbursed at the rates of medical visits. And that is a disincentive. You know, I personally am a fan of single payer healthcare systems. You know, I know some of you aren't, but you know, and the reality is we don't live in one of those systems. So, you know, we require insurance in order to provide services. And if we don't get paid as much, like we can't expand services, we can't pay staff as much as they deserve, and that, you know, to keep people in the system. So I just think a lot of advocacy work needs to be done at governmental levels. And also things to end stigma, I think is very helpful. The fact that you're all here and you all clearly take behavioral health care seriously is huge. So please keep talking to your friends and neighbors about why behavioral health is really important, and tell your Congress people that as well.
Thank you for following up with that, Dr. Gannon. There is a question that said, is there any data or access to mental health for the Spanish or the Hispanic population in our area at all being done? Is there anybody can comment or weigh in on that?
just say that it's usually provider specific, and so sort of scattered throughout various clinics, we may be able to identify psychiatrists or therapists who are bilingual. So always an important question, but I think that I don't know of, and maybe somebody else can correct me, of specific Spanish speaking only or bilingual clinic. And so it's really provider specific and patient specific.
Yeah, through UPMC, there is a Spanish speaking clinic. I'll see if I can find the website and URL and paste it into the chat.
Okay, so we're going to move along to some of the questions that some of our people prior to that submitted. How could you, this question is more so about support. How can you support people that's dealing with frustration and just get despair about long COVID? Does anybody have some? I know it's kind of a broad question, but
very important to acknowledge that many people are still living with the consequences of COVID infection and long COVID that's affecting and impairing their functioning, and to provide the care that is validating to these individuals, that acknowledges that this is a syndrome that we know now more about, but we also need to do more studies to identify who is at risk for long COVID once they are affected by COVID-19, because we are now, while the pandemic has ended, we are living with the virus, and the virus will continue to exist, and some people are going to be more vulnerable to its consequences, including long COVID.
thank you for that. And this is another kind of question, more community-based, but it's about what was spoke about on many of the panelists today. How can we build more community support to those who lost loved ones during COVID-19? Or maybe just you can recommend some current things that we're doing here within the hospital or the university to support those that lost loved ones.
I think in part just acknowledging the loss. I mean, we lost over 1 million Americans. And I think also acknowledging that people did die of COVID-19, because I think another element of people's grief with this is that, you know, there are people online, I want to say trolls, but, you know, some of them believe what they're saying, but there's a lot of misinformation, you know, that COVID isn't real or your loved one didn't die of COVID. And I think that's really can be a real kick in the gut when you're already down. So I think just talking about it, acknowledging it, being there for people, and certainly I think in behavioral health we would do, you know, treat grief like we always do, but also acknowledging that would be important. Yeah.
Okay, we're gonna do our final question, and this was directed towards Gina. Has telehealth improved access to care?
Yeah, I would say in many ways it did, especially in rural locations where it can be really hard to find a psychiatrist in general. We've been, a lot of either telehealth companies or us specifically have been able to I use the word beam a doc into rural locations. And that's been incredible to be able to provide care where there isn't a lot of access. I mentioned before, there were some people that when we tried, we had at the beginning of COVID had to make this huge shift to almost all virtual. There were people that then were left out, and that is of concern. So that did not improve access for them during that pandemic time. And then one interesting thing that our teams were able to do during COVID is really rapidly shift a lot of our intensive outpatient programs and partial programs to be by video. And so for some patients, if they had that IT tolerability and access and still felt connected, we had people who normally would not have been able to participate, for example, like in our eating disorders partial, who then had access to something that was never in their community before. But then at the same time, there were others who were more comfortable with in person and couldn't translate to video. And so I think kind of goes both directions.
Well, thank you for that. At this time, I just wanted to thank all of our participants that registered for this event for our very first Health Sciences Health Academy virtual event, highlighting Department of Psychiatry's work that's being done. I want to say thank you to all of the dynamic panelists. Thank you for your time and willingness to discuss this very much needed topic of SOS, surviving of self. The impact on COVID-19 has been a great one that we are very much living and experiencing today. So I thank you for the time. I thank you for all of our participants with Q&A. If you would like to learn more information how to support the Department of Psychiatry's research or have more questions for our panelists, feel free to reach out with me. My contact information is stated on this slide. I just wanted to make note that May is Mental Health Awareness Month. So this was the most important reason why we chose this month to talk about this today. Thank you. Have a great afternoon. To all the participants, thank you to the panelists. We greatly appreciate you.
Thanks for having us. Thanks everyone for coming.
Bye. Enjoy the rest of your day.
Thanks, Deidre, for an amazing event.
Thank you.